Welcome all. Today we will welcome all. Today we will discuss about perioperative delirium. Delirium is a very common problem postoperatively, but it is hardly diagnosed. To diagnose and manage delirium, there are four important aspects of it. First, we have to recognize delirium or diagnose delirium, assess delirium. We should know how to prevent it, and we should know how to manage it. What is delirium? To define, delirium is a disturbance of consciousness with inattention that develops over short time and fluctuates. That means any change in patient behavior or consciousness postoperatively should be evaluated for delirium. What is delirium? It is an acute confusional state and it generally has a reversible cause. It is characterized by presence of inattention and it is always a sudden onset. Why should we use delirium guidelines or why should we diagnose and manage delirium? Because delirium can result in increased morbidity and mortality, increased length of stay, increased rate of readmissions. So it increases rate of admission in long-term care facilities and 20% of patients discharged post hip fracture in one of the studies still had evidence of delirium. Now let us see the outcomes of delirium. As you can see, only 40% of patients who develop delirium completely recovers. 25% has permanent cognitive impairment and 35% increased risk of mortality due to delirium. Even with complete recovery, 30% rate of dementia within 3 years, that is due to decreased brain reserves. Now, how to recognize delirium? Previous studies 32% to 66% of cases are unrecognized by medical staff. And Yale study showed very important finding. Delirium is increasingly recognized by nurses than the physician. 65% of delirium were unrecognized by physician versus 43% were unrecognized by nurses. What are the risk factors? Four independent risk factors. Vision impairment, any form of severe illness or any comorbidities. Cognitive impairment, if pre-existing cognitive impairment always increase the chance of delirium. And another thing is high urea creatinine ratio. Whenever your patient urea creatinine ratio is elevated, always think that this patient is a high risk of developing postoperative delirium. Four independent risk factors for delirium for nurses to recognize them early. Hypoactive delirium means that patient's consciousness is down, patient will be constantly drowsy. Any patient with more than 80 years of age has high risk of developing delirium, visual impairment and dementia. What are the types of delirium? Delirium can be either hyperactive or hypoactive. So patient can be agitated or drowsy or sometimes you can see the mixed feature. What is the cause? Anything that hurts the brain or impair its proper functioning can provoke a delirium. It is the brain's way of demonstrating acute organ dysfunction. What are the causes of delirium? Causes of delirium are drug, infection. Third one is any system failure or any postoperative adverse events. Metabolic imbalance, dehydration or poor nutrition, surgery or general anesthetics within last 5 days. What are the causes of delirium? Causes of delirium are any pain, incorrect sensory or language impairment, fecal impaction, urinary retention or prolonged urinary catheterization can also give rise to delirium. Any kind of restraint to the patient, sleep disruption, recent severe illness or any event involving hypoxia, particularly cerebral hypoxia, or in 20% of time you cannot find any factors responsible. Now, what are the causes of delirium specifically related to surgery? Perioperative drug, particularly anesthetics, opioids, benzodiazepine, predisposing and precipitating risk factor that we have discussed before. Comorbidities like diabetes, myocardial infarction, etc. All this can lead to postoperative delirium. What are the different theory for postoperative delirium? It can be due to acetylcholine interaction with medication used during surgery. It can be due to increase of neurotransmitters serotonin and dopamine during surgery, previous abnormality levels of melatonin, damage to neurons by oxidative stress or inflammation caused by surgical procedure, or sometimes postoperative abnormal brain waves. Medication associated with delirium. Any drug can potentially cause confusions. All the medication you can think of are generally associated with delirium. Take careful history of any new drug started or any old drug stopped recently. Still, basic reference lists are any antidepressants, antipsychotics, antihistaminics, anti-Parkinsonian drugs, antispasmodics, antiemetics, opioids, anticonvulsants, antibiotics. Unnecessary antibiotics can cause delirium. Corticosteroids, anticholinergics. In studies, drugs with anticholinergic side effects have been shown to lower the cognitive scores in elderly subjects, cause or worsen the severity of delirium, associated with more attention decline in patient with dementia, associated with faster MMSC. Decline in patient with dementia. If drugs are reduced, it is associated with improvement in delirium and dementia. So try to reduce your drugs as low as possible. Now, assessing for delirium. How will you decide that your patient is delirious or not? Generally, it is decided by CAM or confusion assessment method. It has the 94 to 100% sensitivity and 90 to 95% of specificity. Requirement is 1, 2, and either 3 or 4. That is any abrupt change in patient behavior. If patient has any inattention or can't focus, these two are required, either one of the two, or 3 or 4, that is associated with disorganized thinking, incoherent or rambling, patient is using illogical words, or any altered level of consciousness. It can be hyper alert to stupor. So, what are the trigger questions you can think of when assessing for delirium? Is there any acute change in behavior of patient? Is there any changes in function? Is there any changes in cognition? Is there any changes in medication? Or patient is physiologically stable? Generally, these delirium patients are physiologically stable. Now, how to assess for inattention? That is the recite the month backwards or days backwards. Ask patients what you were doing a month before or days before, or have patient count backwards from 20 to 1 and use the CAM score. Now you have identified delirium. Now what? Try to identify any acute medical problem that could be either triggering the delirium or prolonging it. Clarify the premorbid function status, sequence of event and previous admission due to cognitive disturbances, or try to assess the previous admission cognitive baseline. Identify all predisposing and precipitating factor discussed and consider the differential diagnosis. Physical examination is important. Generally, vitals are of normal range. Patients' physical exam should be emphasized in any other cardiology, pulmonary, and neurological systems. Basically, you need to exclude those. Always try to identify patient hydration status, because dehydration is one of the most common precipitating cause of delirium. Also, rule out any fecal infection, urinary retention, prolonged catheterization, or infected pressure ulcer, UTIs, or pneumonia, because all this can precipitate delirium. These are the basic lab work. Generally, all are within the normal, so it can help to differential Differentiate delirium from other causes. How to prevent delirium? Now, various risk factor. For example, if your patient is cognitive impairment, then constantly try to orient patient. If patient is vision or hearing impairment, then provide vision or hearing aids. As you can see, most of the treatments are supportive here. Immobilization. Always try to mobilize patient early and reduce immobilized equipment, because immobilization is a major predisposing factor for delirium. Avoid psychoactive medication. Try non pharmacological approaches to sleep anxiety. Try to restrict use of sleeping medication. Try to treat dehydration early. Try to avoid sleep deprivation. You can use noise reduction strategy, sleep enhancement programs. Prevention and pre-op assessment. Pre-op clinic use and questionnaire. You can ask patient regarding his baseline neurological status, age, any dehydration is there or not. Non-pharmacological intervention. Always apply non-pharmacological intervention in your care plan. For example, initiate toileting routines as early as possible. Mobilize as soon as possible. Try quiet room. Apply soothing music to the patient. Pharmacological intervention. Only use medication if there is non-pharmacological intervention are not successful. The patient is a danger to themselves or others. You may see physician order or a pharmacist suggest the following medication. Sometimes you can use low dose haloperidol, risperidone, olanzapine, and always try to avoid use of benzodiazepine. So basically, you need to support the patient and try non-pharmacological measures. If they fail, then only you can use drugs like low dose haloperidol. It is important to remember that dosing best given when agitation becomes a concern or becomes a safety issue. Medication must be discontinued once the agitation from the delirium is resolved. Thank you very much.